All right, like Karen said, we're going to talk today about various assistive devices and different gait patterns. And it's a very informal lecture, so anytime you have a question, please stop me, all right, and ask. And feel free to share your experiences with us, too, if you have. All right, so what do we want to accomplish with this lecture today? So you're going to be able to identify what safe ambulation is and the different components of it, the different types of assistive devices that we're going to talk about. We have a lot of them here, but we definitely don't have all of them. You're going to talk about pros and cons, because there are cons to using an assistive device. We're going to talk about different patterns, gait patterns of using assistive devices, and we're going to talk about proper guarding techniques. All right? All right, without looking up here and at your paper, why is it important to maintain somebody's ambulation? Why? Why is it important to walk?
So they can get around, meet their needs. Function.
Get around, meet their
Activities of daily living.
ADLs.
Quality of life.
Quality of life. These are all wonderful. Absolutely. How about physically? What does it do for us physically?
Loosens you up.
Promotes health.
Range of motion, she says. Promotes health. Cardiovascular.
Exercise.
Cardiovascular. Weight bearing. Right? So our bone density stays strong. It helps our GI system. It helps our respiratory system. It helps everything to be upright. Right? Standing. I work with a lot of disabled children who are wheelchair dependent. And it's just so important just to even get them weight bearing. And I'm going to show you towards the end of the lecture some different standing equipment that we have just to get them up, and some gait trainers. And psychologically, somebody mentioned that, I think, it just is very important to our psyche to be able to walk and to take care of ourselves. Absolutely. Complications of immobility. What happens? We get decreased range of motion, decreased strength. We get pressure sores, right, from staying in one position too long. You can get respiratory complications, etc. All right, so it's very important. All right, let's talk about walking. First and foremost, this is kind of silly that I mentioned it, but it's not. You want to make sure that your patients wear appropriate foot attire, okay? I've worked in various settings, and I've seen patients who wear the flip-flops, who wear the high heels, who wear the slippers, who wear those hospital socks are terrible, you know, the treads on the bottom of them. So you want to make sure whatever your patient's going to ambulate in, that they're going to be safe. I had this older lady in the hospital once. Oh, she was a pip. She was hysterical. The red lipstick going, and in the foofy bath, you know, with the fuzz and the bath. What do you call that? Robe. Thank you. And she had the highest heels on, and she was very demanding that she use the highest heels. You know, we had to talk to her and tell her, you know, it's not so safe. We compromised with her. She got to keep the lipstick on in the bathrobe, but you want to make sure that your patient's safe when you're walking them. Okay. Again, you want to check for your patient's cognition. Do they know what they're doing? Right? It's very important that somebody knows how to use the equipment, that they know their surroundings, their vision. Can they visually attend to their environment? You know, can they see when it's not safe to walk someplace? You want to make sure your patient has enough strength, endurance, balance. You want to make sure while you're walking with your patient or your patients by themselves to monitor their physiologic response to ambulation. Does anybody know what I mean by that?
Color?
What are you looking for?
Maybe their color in the
Color,
face?
yeah. What happens if it goes from normal to white?
Drains.
That's not a good sign. Something is impaired. You're going to look for sweating. You're going to look for their heart rate, right? All of a sudden, they become short of breath, or their pulse rate or their breathing becomes very labored, right? What else are you going to look for?
Steadiness.
Steadiness, if their balance starts to go. Very good.
Did we say labored breathing?
I did, but it's good to say it again. A couple weekends ago I was teaching the weekend class, and one of the students in this classroom had told us this story. It was unbelievable. It's never happened to me in my 21 or 2 years, I don't know how many years I've been practicing, but she told us, I think she was an aide in a nursing home. She was walking with a patient, and she noticed that his color was, you know, he looked kind of like grayish, whatever, but I think it was more typical for this patient. and she walked him back to his room, and didn't think things looked all so good, so she went to get somebody. Come back and they were dead.
Oh my God.
That's quite a story. And it is an extreme story, but it's a story for you to really think about. Because you need to be cognizant and aware of what's going on with your patient. Maybe they can't verbalize, to you, I'm not feeling well. So you have to look for these different reactions and responses, okay? That's extreme. That's a little extreme. Thankfully that's never happened to me.
Now we're all gonna be terrified.
No,
I know,
don't
right?
be terrified. But I want you guys to be aware. Okay? Don't be terrified. If you ever feel like you're not sure what's going on, ask for help. Don't ever feel like you cannot ask for help. Okay? It's your patient safety and your safety. All right. I told him that godforsaken story.
Oh, yeah.
Okay. You want to make sure you're going to utilize a gait belt. We're going to go through later in the lecture some contraindications and precautions to using a gait belt, but you want to make sure for the most part that you have a gait belt on your patient when you're walking them for safety. Okay? Make sure the assistive device is measured properly for your patients. We're going to go through that as well. Typically, the physical therapist or OTR or whoever will have the equipment adjusted properly for your patient, but there's numerous times that I can think of that either somebody took their equipment, let's say in the hospital, right? We're all sharing equipment left and right. And someone said, oh, here, just use this walker. Well, it might not be fitted for them properly, right? So you want to know how to do that. You want to make sure it's fitted properly. You want to make sure that the area that you're walking in is clear of clutter. Like this wouldn't be such a good, area for somebody to walk in who doesn't have good balance and stability and coordination. So you want to make sure, and especially in the home, the patient, if they're by themselves and they're using the assistive device, do the rugs, are the rugs there? Are there different obstacles, cats, dogs, whatever that they have to encounter? All right, so you want to make sure when you're walking with your patient that it's safe and clear of clutter. And be prepared for anything. Anything can happen. All right, any questions so far? Anybody have a story like that for me? Thankfully, no.
A really good thing, you guys, when you're working with your patients is to actually, Kari's bringing up the issue of carpets and different
Yes.
floor surfaces. You really want to practice with your patient on different surfaces, right? And a lot of times in rehab, there actually will be sort of simulated apartment with some carpeting so that you can actually practice with the patient not only ambulating on the carpet, but the transition between one type of floor surface to a different type, and how they're going to negotiate that. So it's something you need to be cognizant of. Yeah.
Yep, very good. Very true. All right, let's talk about pros to using an assistive device. All right. What does an assistive device do for you? Right? Anybody shout on the answers?
It enables you to do something that you ordinarily may not have been able to do.
Why? What does it do for you?
It sort of stands in the gap for what you're missing.
Which is?
I don't know. It assists you. I don't know.
With what?
Balance.
Balance.
Oh.
What's missing? Balance might be something that's missing.
Mm-hmm.
Strength, right? Might not have a strength. Go ahead.
Range of motion.
Range of motion. Might not have all my range of motion. Anything else? You might have an injured extremity, and you're going to reduce the weight off of that injured extremity and transfer it to your arms. So let's say in your legs, right? Weakness. Did we say that?
Mm-mm.
Okay, compensate.
Strength.
I did say it. So yeah, that's the same. So it's compensating for the weakness. All right. Safety, balance. Anybody think of anything else?
Vision.
Vision.
Low vision.
What?
Low vision.
Low vision, yeah. They teach visually impaired. I worked with a visually impaired student who used a cane. Yep, very good. I didn't think about that. That's very good. What? Good job. I wish I had some candy to throw at you. All right, here we go. So let's talk about the negatives to using an assistive device. We all think it's all good and well, but
Become dependent.
I like that. I love this. See, this is why I opened it up. You guys are just so smart. That's right. You can become too dependent on it, right? And what happens if you use it and you don't need to be using it?
Prevents you from regaining your strength or
Right. You don't regain your full mobility or strength or your functioning. Very, very good. Also, from prolonged use, can you think of some things that happen?
Sores.
You get sores maybe. Very good.
Also, it can
Muscle
sort
atrophy.
of make you uneven. Like if you rely on something too much, then the other side is working too hard maybe, so you're not in balance.
True, and also not in balance. The other thing is it can get in the way, right? It can actually cause you to trip and fall if you're not using it properly. Very good. You could develop tendinitis, right? From overuse syndrome, right? Anybody else? Okay, so I have inappropriate device prescription. What that means is sometimes the physician or whatever happens, this individual or patient does not have the appropriate assistive device for them. We're going to go through in a little bit and talk about somebody who has like impaired balance, or somebody who doesn't have, good cognition or good stability, and what assistive device would be better than the other. Okay, so sometimes, let's say I'm frail, I'm elderly, I don't have a good lot of strength. Would I want to use a straight cane? Where's my straight cane? Or would I probably be better off using, see, I start to move, I'm sorry. I move all over, don't I, Karen? A walker. Which one would be better? A walker. Well, let's say that she was prescribed this. It might not be the best thing for her. All right, so sometimes assistive device and equipment is prescribed inappropriately. Inadequate user trainer. Nobody taught them how to use it. Mrs. Jones got this from a neighbor, right? Oh, George has this you can use, so he gets it, right? But they don't know how to use it properly. I'm going to go through it in a little bit. Oh, I feel so bad.
It's fine.
Okay. I'm on the go. I'm going to teach you how to use the assistive device properly, but let's say it's typically used opposite your affected side, because they're going to go together. These two are going to go together, all right? You all are going to get this, believe me. All right, so maybe you guys, I always use this analogy with House. Anybody ever see House? How does he walk? Right? What is he doing? He's got the cane, the assistive device. He has, I'll do a dance for you. He has it on the affected side, right? It's not supposed to do that. It's supposed to be opposite the affected side. Okay? So that it can provide stability for that
I
side.
didn't know that.
I always wondered which side it went on.
That's what side. Yeah, they go together. Think about it. If this is going, yeah, it provides a nice wide base of support for you. They go together, and it's opposite. It's not on the affected side. House thinks so.
You would think it would substitute for what has a problem.
Yeah, you see it all the time. You see people doing this,
my
right?
mother, I think my mother uses it.
I'm sure.
I
I'm
need to
sure.
ask her.
But she probably taught herself again, right? So that's what I'm talking about. Inappropriate user training. Use of non-prescribed devices. Just pick it up because so-and-so has it. Another con to it is, like we said, repetitive stresses. We already went through this. And it actually might get in your way. All right? Any questions? Examples? Anything? No? No? Okay.
So
I like stories.
I know that Kari already talked about this, but patient cognitive status is a huge deal when you're giving them an assistive device, right? Do they understand how to use it? Is there going to be carryover? Is there going to be generalization, right? What's generalization? Like being able to take it, do it in one context and then generalize it to another, right? And I gave an example in the first lab this morning about a woman who I was working with recently who was prescribed a cane, and she was given a 3-point gait, which Kari is going to take you through. So I went in to work with her in the room, and I said, okay, show me how you're using this. So she showed me properly for the first couple steps, and then she stopped using it correctly. She started doing it a completely different way. And I had to say, wait a minute, this is not appropriate here. And so what had happened was, I think that she was a new patient. The PT and OT who had been working with her and evaluating her thought her cognitive status, that she was completely intact. They didn't know her that well yet. They hadn't seen her over a period of time. And so then I came in and I had to say, wait a minute, guys, this might not be the appropriate choice here. So, it's just another example of how we're constantly evaluating our patients and how we can't take anything for granted. I might have just been like, oh, okay, she knows how to use this cane, no problem. Go ahead and go, I don't even need to be near you. Go ahead and go. Because she almost used it incorrectly and almost fell. So, we really need to just keep that in mind.
Yeah, true. Thank you. All right, let's just talk quickly. I'm gonna have pictures and we're gonna go through each of these assistive devices on their own, but let's just quickly talk about what is out there. We have canes. This is a straight cane, all right? And then we have what's called a quad cane. It has 4 legs, therefore quad, all right? And we have what's called a hemi walker. And I don't have that, but I will show you. Has anybody seen it? It's just like half of a walker. It's more stable than a quad cane, okay? I have a picture of it later on. All right, and then we have crutches. We have axillary crutches. These are the typical crutches that everybody has seen, and probably who's used these? Anybody? Yeah, I'm sure. Yeah. All right, these are axillary crutches. We're going to go through proper use and function of these. And then non-axillary or lock strand. They're called forearm or lock strand crutches. That's what these are. Has anybody ever seen these?
Mm-hmm.
Okay. These are loft strand crutches. And then we have walkers. We have all different types of walkers. We have an anterior walker, a posterior walker. We have walkers with wheels. We have walkers without wheels. We have walkers that have platform attachments to them, baskets, seats, everything. All right. Those are walkers, and we'll go through that. Any questions? So, how do you select what is the appropriate assistive device for your patient? Well, you typically are not going to. Somebody else typically will. But, again, like Karen said, you're going to constantly be evaluating and reevaluating. Maybe Mrs. Jones was given, a walker in her cognitive status, or a cane. In her cognitive status that day was fine and she was using it properly, but the next day something happened. Maybe she had a TIA, she had a mini stroke or something changed. Maybe medications aren't working right, which can affect your cognition, and she's not using it properly and she's not safe. That's where you intervene. That's where you talk to somebody and say, wait a second, I don't think that she's safe. She might have been yesterday, but she's not today. And you bring it to somebody's attention, okay? So selecting the appropriate assistive device is based on how much stability and balance that somebody has, how much cognition they have, right? How much coordination. It takes coordination to use these equipment, all right? How is their range of motion? How is their strength, etc. So what I'm going to do is in the next couple slides, I'm going to go through what is the most stable assistive device to the least, to the most coordinated to the least, okay? All right. Least coordination to the most. Parallel bars. Anybody ever seen them in the hospital? They're just there. They're set. The patient doesn't have to worry about advancing any type of, assistive device. It's there. It's stable. It's anchored. Easy to use. Then we go to walker. This does not take a lot of coordination to use. You would have seen this too, Karen. Has anybody ever seen that?
My mom.
Yes,
So funny.
yes, I love it. It cracks me up. Like, I don't think you need the walker. So you have, the rolling. That's very easy. It doesn't take a lot of coordination. It's just a push.
But you really need
Okay.
the tennis balls for it to roll, right?
No,
In
you
the
don't.
back? Oh, you don't? It just rolls?
It goes better with the tennis balls, but no.
Okay.
They actually have some sliders too that they can put on too. It depends upon what surface you're walking on.
It looks like the walker's on skis.
Yeah, it does have little skis. That's what it looks like, a little slider. So it doesn't take a lot of coordination, right? Lifting it up and advancing it. Still not a lot of coordination, but you have to remember to do it, right? All right, then it goes to one cane. It's a lot easier to use one cane than it is to coordinate with two canes, right? And then axillary crutches, which are your typical crutches. And it really, really takes the most coordination to use loft strand. You guys can practice this. We'll have a lab in a little bit, okay? And you guys can practice.
How do you say that again? Lob the what?
I'm sorry. Is it not on there? Loft strand. I'll write it down.
I think it's on
on one
there
of
on
them?
different slides, but not on that particular one.
Loft strand.
Thank you.
Yep. That's the same as forearm. Yeah, it's on a different slide. Okay? These take a lot of coordination. Any questions on that? Or comments? Or disagreements? I love it when people are like, come on, bring it on,
I like your sparkly shirt. How about that? When you go in the light, it sparkles all
Love
over.
it.
It's
Thank
really
you.
cool.
Are you Sally too? What's your name?
Carol.
We had Sally in the other class, and
Yeah.
she was on the whole time, and I think Carol's on. She's on today. All right. All right,
Okay.
next. Most stable to least stable. Again, parallel bars. Too bad we can't bring parallel bars with us all over the place, right? So parallel bars, those are going to provide the most stability to your patients. Where do the therapists typically bring their patients when they're teaching them how to walk?
To the gym.
But where do they put them? You
Oh,
usually
yeah,
put them in
in
parallel
parallel
bars.
bars.
If you want somebody who, if somebody needs a lot of stability, you're going to put them in the parallel bars. If they're really weak, just out of surgery, post-op, okay? Somebody had a stroke. All right, then, again, the walker. Good old friend walker provides us a lot of stability. It's a very wide base of support. Axillary crutches is next. If you think about it, it's not a big base of support at the bottom of this, but you have to think about the whole picture. So my crutches are out here. I'll talk to you about where they should place them. So right, so then we look. This is the base of support, all the way out here. Not just this. It's what it provides to you. So that's pretty stable. All right. Forearm crutches are next. Then the 2 canes to 1 cane. Any questions on that? No, we're good. Move on. All right, we're going to go through each one right now. We're going to talk about proper fit and measurement and different types of gait patterns, okay? So here's pictures of some walkers. See, look at the basket. Some walkers also have brakes on them. See, this has a brake right here. It's supposed to work.
Oh.
Don't work. Doesn't work today. Some have wheels, some don't. There's a standard walker. The standard walker has no wheels. And there's a picture of a walker with platform attachments. Has anybody ever seen that? Can anybody think of a reason why an individual might need to use a platform?
Bend over.
I love everybody thinking of this. I don't think it's used for that purpose, but I think that that's a great idea. Yes?
This lady at my work has one, and she has something wrong with her legs, so it helps her to stay up more, so she can lean on it more.
That is interesting that everybody's saying that. But yet you're bringing them up higher, is what everybody's saying to me. And I do understand that. Yeah. Typically, go ahead, what'd you say?
Oh, it was just, yeah, instead of being hunched over.
Yeah.
Does it help to open their airway?
When you measure the assistive devices, you're really not supposed to be hunched over when you're using them. Okay,
So it could be an
it's supposed
improper
to be
fit.
measured properly so that you don't have to hunch over to reach them. So,
But they might be talking about a strength thing. Yeah.
Mm-hmm.
You know what I mean? It might be a strength issue that they don't have the ability to come up. Yes.
Does it have to do with like holding your shoulder up? So
And somebody with a stroke. It might be with somebody in a stroke who doesn't have a sling or something on or can't keep their arm up very good. Yep. Also, if you have orthopedic injuries, if you have any type of fracture and you're non-weight bearing, that's where you'll want to be. That's where you see it a lot. And also, if you have like maybe overuse syndrome or tendonitis or something going on in your wrists and hands, that they can't do it, then you'll see a platform attachment. Everybody's mentioned that.
So it's
funny.
basically used for like fractures? Is that what you're saying?
Yes, yep, if you have a fractured arm. People in motor vehicle accidents, I used to work with them in the hospital all the time. You would have platform attachments all the time.
although it depends on where the fracture is.
Yeah, it does.
You know, if it's a humeral fracture and they're putting weight right through that humerus, I don't know.
That
if
wouldn't
that's not
work.
good
If it's a
choice.
forearm
If it's a wrist or
Or
forearm,
wrist,
it
then you'll
might
probably be fine.
So,
What also if you just can't extend your arm all the way? Because of the lack of range of
If
motion.
you have a
then you're-
contracture, is she saying if you have a contracture? Yeah.
right, yeah.
Yep, very good. Yep, actually in some of the pediatric kids that I work with who have too much muscle tone,
Mhm.
and actually we do in the gait trainers, we do use those for posture. Very good, guys. See, that's why I like talk. You guys teach me. That's why I like to teach, because I learn from you guys. All right, so let's talk about walkers. All right, that's the first piece of equipment. It's the most stable, provides us the most stability, and it's the easiest to use. Doesn't take a lot of coordination. It really increases our base of support, right? It's going to improve our balance both anterior, posteriorly, and lateral stability. The weight is definitely transferred off of our legs into our arms. All right? So you're going to use this with somebody who is a high level of support. They need it. They're frail, they're weak. They're either non-weight bearing, we're going to go through weight bearing status, they can't put weight through one leg. You want something that's going to provide a nice stable base of support for them. okay? Somebody who has poor balance, coordination's terrible, you definitely wanna come up with a walker. And it's used with any weight-bearing status. All right, let's talk about, see, I want everybody to be able to see me when I do this. Proper measurement, okay? So again, you're not gonna probably fit your patient for this, but if you go to your patient's bedside or wherever you're seeing them, if the equipment's not there and you have to get another piece of equipment, you need to know how to set it up. If you don't, or you don't feel comfortable, ask, all right? But I wanna teach you guys. All right, so height, how high? It should go right to the greater trochanter. All right, the top of the walker, it's on there, should go to the greater trochanter. My elbow, you're gonna see this carried through for all the assistive devices. Elbow should be flexed 20 to 30 degrees. 20 to 30 degrees elbow flexion. You don't want my arm straight, and you don't want it up here, okay? Okay, position the walker 10 to 12 inches from the front of you. You don't want it here. I've seen this. Oh, you've never seen that?
No.
Oh, I've seen it. Especially if it has wheels. Yep.
You want it how far in front of you? 12? Oh, 10 to 12 inches.
You got it. Carol, no.
Yes.
Wow.
You are good.
Oh, no, I'm not good. That was lucky. All right. So Scott, you guys all know Scott, right? Karen's probably sick of this story. I've told it a million times, but he was working with a patient, right? And he was trying to explain to the patient to keep the walker, you know, within the base of support. She says, "Oh, you mean keep the chickens in the coop?" Yeah, keep the chickens in the coop. It's hilarious. You
Whatever
don't get it?
works, you know.
I know, but the patient said that. That's hysterical. Whatever works. So you don't want here, because you obviously can't walk if it's too close, and you don't want here. All right? Okay, so different types of gait patterns. We're going to go through that, but I'm going to introduce it to you right now. The most common, if you have an injury, it's not a fast gait pattern, but it's the most stable, is what's called 3-point. All right? And in my last class, Sally, I said, "What is that?" She goes, 1, 2, 3. I said, "That's it." All right? But you need to know what 1, 2, 3 is. Ready? It's assistive device. Always first. That's 1. Affected. Extremity. Then not affected. Okay? So it would be walker, my injured leg, my left leg, then my good one. Walker, left, right.
Can you do
That's
some more?
3-point. You want me? What do you want me?
Can you just do it some more?
Some more. I could do it tomorrow. Right,
Because
here
I was
we go.
writing when I was.
Yeah. So adaptive equipment, assistive device. That's 1. 2 is affected extremity, not affected.
Okay.
1, 2, 3. 1, 2, 3. Okay.
Mhm.
You can do that in a non-weight bearing. You can still do a 3-point in non-weight bearing. What that means is it's walker, equipment, swing through my affected leg, and then my non-affected. That is still a 3-point. Even though I'm swinging, it goes first. Got it?
You do weight bearing status?
Yeah, I can do weight bearing status right now. It's on the top of page 12, I think. I will put this. It's on. If you want to, guys, go to the top of page 12. So let's talk about the different weight bearing statuses that there are. There's full weight bearing. I can just fully weight bear, no limitations, right? Then I have what's called partial weight bearing. The doctor may prescribe if you have a total hip replacement or knee replacement. I only want you doing 20% of your weight. So the therapist would figure out, you know, sometimes we get a scale out and say to the patient, that's 20%. You can't use more than that. So that's what's called partial weight bearing.
Mhm.
You can only use part of your weight. All right? And then there's what's called toe touch or eggshell. Your foot is only there literally for balance. You're not weight bearing through it. That's called toe touch or eggshell. Okay? And then you have what's called non-weight bearing stat. Non-weight bearing. No weight. Can't put any weight through it.
Wait, I'm sorry. What was toe touch again?
Just
Say that again.
balance. Toe
Just
touch.
balance. Toe
Toe
touch.
touch.
Okay.
Okay? Any questions on the weight bearing status? No? Yes.
What is the WB?
Weight bearing stat. WB
Weight
what?
bearing as tolerated.
As tolerated. I'm so sorry.
That's fine.
Thank you for asking. All right, so that's a walker. That's going to provide us with the most stability. That's going to provide us with somebody who has the least coordination. All right? Axillary crutches. Let's talk about these. Now, these provide lateral stability. It definitely improves your balance, and it's going to take weight off of your legs. right? What's, what should I not do with these? What's a contraindication?
Oh, you don't want
or
them under
precaution,
your,
a precaution.
you don't want them through your armpits?
Yeah, you don't want to weight bear through your armpits, because we have what? What's going through there?
Oh, you have nerves and stuff?
Nerves and stuff. I love that. I wish I could have done that for the brachial plexus. Nerves and
I took
stuff.
anatomy a year and a half ago. No, 2
I
years
agree
ago.
with
so
you.
I'm a little,
It's been 25, 23 years. Nerves and stuff sounds good to me. Got it. You have brachial plexus going through here. So if you weight bear like this, you see people doing it all the time, you can damage. You don't want permanent damage. All right? So when you're teaching somebody to use crutches or talking to them about it, make sure you explain to them the importance of putting the weight through your hands, not on your armpit. That's why it's important to have it properly fitted. Because if it's not, then you're probably going to do more of this, right? Because these are not fitted properly for me.
Do they tell people this, like
Yeah, you
regular
should.
people when they break a leg or something? Because I feel like nobody.
They don't listen.
Okay.
It's
maybe
mostly the
just
younger
like,
population.
okay,
They don't
yeah.
listen.
Because I think most of the people I've seen in crutches are in high
So-
school age. So.
My daughter, 12 years old,
Okay.
wanted crutches so bad because it's so cool.
Right.
She done. She's
No,
crazy. Just
I-
like she wanted braces.
No, I mean I understand it because I always saw them and I was like I've never been injured. What's up with
Yeah,
that?
exactly. So it's the cool thing to do to walk fast with these, right? No, it's not the cool thing to do. Well, it is the cool thing to do, but it's not the smart thing to do.
And then everyone complains they hurt.
Yeah. Oh, I don't want these anymore.
Now
You
I know
know.
why. They're not using them right.
Exactly. So it is very important for you to teach your patients the proper use of them. Okay? Even though it might be on deaf ears, because that's what happens. All right. So in order to use these, you have to have good what?
Upper arm strength.
Good upper arm strength. You got it. Do I have to have pretty good coordination too? Pretty good coordination to use these, especially if you're going to use what we're going to learn later, a 4-point gait pattern. Ay, ay, ay. Right? Nobody really uses that. Well, I can't say nobody, but. All right, so coordination, balance, all right? And typically, I say typically, for most of the population, it's used for short term. Reason being, because we just talked about it, there's potential for injury. All right? Typically, if they're going to use crutches, we'll have them use the loft strand forearm crutches for more chronic, long-term use. Okay? All right, let's talk about fit. How do we fit these? Oh, there's pictures. Oh, important considerations. Did we talk about all these? Weight through your hands, not your axilla, your armpits. Elbows close to your side. You don't want this out to the side, right? You want them in, elbows close to your side. Take your time. Do not rush. And make sure you keep your head up. Have you ever seen people walk like this?
Mm-hmm.
I've seen it. I've seen people walk like that. They need to look up. Somebody could run in front of them. They could bump into them, right? They need to visually scan anything. You know, animals running in their path or whatever. All right, now we're going to talk about fit. So how do we fit these? What is the proper fit? Gotta go down over here. So the top of this should be 2 inches below your axilla. Not fitting me properly, is it?
Nope.
No. All right. 2 inches. Now, base. How far should it be from my body? Approximately 4 to 6 inches away from my fifth toe. Okay? So you don't want them out here. You don't want them too close. It's a basic judgment, 4 to 6. Hand piece. My elbows, again. What are my elbows going to be? Flex to
20 to 30.
20 to 30 degrees. You got it. So on these crutches, there's a hand piece adjustment, and then there's a height adjustment. On the newer ones, not the wooden ones, which I date myself by saying this, but these give you heights.
Yeah.
You can cheat. Typically it works. All right, so if somebody's like, how tall are you? You're like 5'2". Oh, 5'2". There we go. All right? So now that we know how to fit properly for our patients, how do we use them? Let's talk about the 3-point. If you guys can remind me, what is a 3-point? What do I have to do?
Device.
Assistive device?
Affected leg.
Affected?
And then
Not affected.
Excellent. So assistive, affected, not affected. Now let's talk about that using different weight bearing statuses, okay? PWB, partial weight bearing, right? So I would do the same thing. I would advance my assistive device. I would put part of my weight through my affected leg, then my other leg. Right?
Mm-hmm.
All right, non-weight bearing. What do I do? Crutches, swing my
Yep.
leg through, then my non-affected. All right, and weight bearing as tolerated, WBAT. So it would be crutches. As much weight, the doctor said I can put all my weight on, but I'm just learning and I'm still in pain. So it's crutches, I put as much weight as I can tolerate, and then my sound leg. Okay? All right, let's go through, everybody understand 3-point?
Mm-hmm.
All right, 4-point. It's a little more confusing, but it's exactly what it says. There's going to be 4 steps to it. Okay? So, my left leg is injured again, right? This is a very slow gait pattern. I would advance my right crutch first. Then I would advance my left leg, whatever weight bearing status. Then I would advance my left crutch and my right foot. So let me do that again for you. All right? Injured left leg. Right crutch, left foot. Left crutch, right foot.
Injured
One.
left leg, you said.
Yep. 1, 2, 3, 4. 1, 2, 3, 4. Does that make sense? It's a slow gait. Yes.
Can you repeat it just
One more
Absolutely. Yep. So we always know that assistive device goes, right, and then are affected. They're partners in crime, they go together, right? Okay? So my assistive device, my crutches, let me start that again. My right crutch, and then my left foot. Because you always want to use opposite, right?
Mm-hmm.
So it's right crutch, left foot, left crutch, right foot. 1, 2, 3, 4. 1, 2, 3, 4. That's a 4-point.
I just think about like an animal crawling.
She just said it. I'm going to put a picture of my baby up there. She's 8 months. She's crawling.
Oh.
And that's what she does. 1, 2, 3, 4. Exactly.
The first thing I thought about was like a big cat, like
It's
when
exactly.
like hunting.
Exactly.
That's what I thought of.
I really need to put a picture up there. It's exactly what it is. Very good. Yep. It is. It's very, very, that she goes very slow. She does the 1, 2, 3, 4. Yep. All right. So that's 4-point. Now, can I use that with a non-weight bearing status? Would you use that if somebody like can't put weight through their leg? Probably no. Right? Does that make any sense? It's common sense. It really is. All right. I am going to go through a 2-point later, but I'm just going to quickly mention it. Now, to speed up that 4-point gait pattern, you can do what's called a 2-point, and you will see people use this. So, what does my affected extremity go? Opposite, right? So I would then do my right and my, so it's my injured left leg. So my right crutch and my left leg are going together. Then my left crutch and my right foot go together. So it looks like this. 1, 2. 1, 2, 1, 2. That's a 2-point gait pattern. Make sense? 1, 2. Make sense or no?
Can you
Yeah.
say it again?
I can say it again. I
Thanks.
can. I can say it in my sleep. Here we go. Ready? All right. So my injured left leg. Ready? No, you're not. Carol.
I'm sorry, I
See?
was-
I'm gonna call you Sarah. Carol.
Whatever.
Right crutch, left foot together. Then my left crutch and right foot together.
Okay.
1, 2, 1, 2.
What kind of like,
That's a 2-point gait pattern.
what kind of people would? Because I've never seen that. Like, what injury would they
You
have? to use that?
you can have somebody who has some type of neurologic disorder. I've seen it with CP actually. I've seen it with kids that use that. Somebody who maybe MS.
Yeah, that's
So it could be either leg with that.
Either leg. I'm just giving the example. Exactly.
The law strand for that though, not.
You could.
Okay, that's why I was confused because that I've seen before, but I haven't seen it.
You could. But I had a student in the class a couple weeks ago say, because I said this is short-term use, right?
Mm-hmm.
Say, well, so-and-so's used crutches all their life. Some people do that. Probably not the best thing for them, but everybody to each his own, right? As long as they're not injuring themselves, as long as they're safe with it, and functional with it, and independent with it, right?
Right, so remember Kari said that the lock strands are for longer term use.
Right.
The axillary crutches are for short term use.
Yep.
So you might be using the axillary crutches as training, right, to do this gait. possibly, and then maybe they'll move to Lofton if they might need them permanently, or maybe you're giving them the Lofton right away, but.
Right.
So that might be a reason why how it's.
Very good
That makes
point.
sense.
So you've already
Yes, Carol?
said this, but, so basically, to do the 2-point, you could have weakness in each leg at the same
You
time
could.
even?
Absolutely.
Okay, thanks.
Absolutely. Yep.
What is it called when you move like both crutches out? Like if you have like a broken leg, you move both crutches at once.
You're gonna answer this for me. Are you ready? I'm moving my assistive device, I'm moving my broken leg, then my left leg.
See, when I broke my leg, they told me to keep like my hips together and move it like as one. Like don't swing my foot forward.
Okay, so one, like this.
Yeah.
And then if you do it like that, not swinging forward per se, it's more of a 2-point. But it really is a
Or it
3-point.
considered a 3-point?
It's considered a 3-point. Very
The
good.
2 and 3 are going together.
The 2, 3 together. So what she's saying, everybody, because I said swing your injured first, and then the other one, she's saying is she had to keep her injured and her sound leg together. Then if you keep them together, I would consider it more of a 2-point. But that's just like technicality. Let's not go there. Thank you for bringing it up, though. Any more questions with that? You guys will have a chance to practice. So there's our loft strand. There it is. Our forearm crutches. Let's talk about function. Again, it's used for more chronic long-term use, okay? You have to have fairly good level of coordination. We had somebody in the last class say, well, I knew somebody who was very athletic and he was like 50-something and he was very strong, he had good upper body strength and he injured himself and he was using the loft strand crutches. So, it's just, it really is, as far as, you know, it's to each his own, as long as I said all the criteria is being met. Alright, so basically 40 to 50% of your body weight is transferred from your legs to your arms. And you have to have pretty good upper body strength to do this. Any questions with that? Let's talk about fit. Okay, I'm coming over here again. Proper fit. So again, what are my elbows in, everybody?
20 to 30.
20 to 30 degrees. All right, this is, first of all, they're not the same height. The forearm is not the same height, and it's not 20 to 30 degrees, is it? Okay, so I want 20 to 30 degrees of elbow flexion. How far should it be from my body? 4 to 6 inches from my fifth toe. You don't want it out here. You don't want it too close, right? And the forearm strap needs to be about 1 to 1.5 inches below your olecranon. This strap right here. So there's an adjustment for the forearm strap. No, not so much for the cuff, but if you adjust this, it'll adjust that for where your hand placement is, and then for the height. Okay? Yes.
Who does all the adjusting?
The
Like,
PTs usually do.
PTs?
Yep. Again, though, something could happen where something becomes, somebody took it and borrowed it and changed it on you, you know? And the next day you got this. What would you do?
Does that happen a lot?